All right, thanks. Thanks, Wayne. Wayne, you and I have known each other for 10 to 15 years or longer, right?
Yeah, at least.
Yeah. Okay, so this will be very informal. I'm actually going to talk today about care home placement and Medi-Cal programs that help with care home placement. We don't deal with supportive housing like helping people stay at home. We have nothing to do with that. So that might be another talk another day. But I'm going to talk a little bit about the different levels of assisted living and private paid, and then also now we're contracted with different managed care plans to help people on Medi-Cal. And then when I get to one part of it, I have a little bit of a PowerPoint presentation about a program called CalAIM. So I started my business about 37 years ago because my grandfather had Alzheimer's and he wandered, and I was my grandfather's conservator. And the doctor said, "Your grandfather wanders, he needs a locked nursing home." And I said, "I know he wanders, but why does he need a locked nursing?" And then we eventually put him in a large assisted living, but he started wandering. And then we put him in a Gero Psychiatric Institute because he was getting aggressive. Then we found him a small boarding care, and he would beat up on residents and jump over fences. And then we put him in another geriatric psychiatric unit for a few weeks. And then we found him another boarding care where it was for 5 years. But he was like a living nightmare because he was very aggressive. And we put him in the second geriatric psychiatric unit. Um, he was better, but it was basically uh, trying to figure out the right setting for him and not having any idea how to do that. And so um, we started about 37 years ago. And so my core businesses were private placement agency for care homes for the elderly. So someone calls us, we get a referral from a hospital, from a senior center, from 211, from Department of Aging, and they say, "I'm looking for a care home for my dad." And then we say, "Okay, so tell me about your dad. What does he need help with?" And we ask a bunch of questions. Does he need help dressing? Does he need help bathing? Does he walk? Does he go to the bathroom? Does he have dementia? What area you're looking in? And then based on area, we recommend homes that we monitor. Most homes we work with for about 10 to 20 years. There's always new homes, but there's a lot of homes that we've dealt with. And then we give the family a list, and it's up to them to find a home. And the way that we're funded is if we make a placement, the home pays us a placement fee. That's all placement agencies work. So we're free to use, but we need to make money somehow. So that's how we work. Every home wants to work with us, but that doesn't mean we work with most homes. So our job is to recommend a good list of homes that we like. And if we're good, the family will go with one of those homes. But we don't recommend every home that wants to work with us because there's a lot of substandard homes. And we're a private business. We're not beholden to anybody. So that's originally how I met Wayne many years ago as we're marketing to Kaiser, different hospitals. But I'm very involved in public policy. And a friend of mine who was the associate director for the American Parkinson's Association, we helped draft a bill related to Medi-Cal paying for assisted living. This was about 20 years ago. Because every other call we get is someone who doesn't have funding for a care home. They need a care home, but they don't have funding for it. And so our job is not to help people go to care homes who don't need it. Our job is to help people that need care homes. So obviously, if someone can stay at home, if they need care, they can hire private paid home health agencies. There's something called IHSS, in-home support and services. If you're on Medi-Cal, depending on the care needs, you can get certain hours to be funded to allow someone to come into that person's home. So that's called IHSS. The maximum for IHSS per month is roughly 283 hours per month. Very few people get that. I think I looked at the state statistics, and on average, most people get about 80 hours per month. So that's for someone that qualifies through the program, through the state, who says, dad needs help, with meals, dad needs some help going shopping, he needs a little bit of help getting out of bed. And the state sends out a social worker, and they determine how many hours that person should get reimbursed per month based on the care needs. So that's one way that someone on Medi-Cal can get some help coming in. Obviously, if they're on Medi-Cal, private paid home health agencies nowadays are roughly 30 to 38 per hour. It's really gone up because the labor laws in California. So if someone doesn't need that much care, that's not too bad. But if someone needs a bunch of care, that adds up very quickly. So that's private paid home health coming into the home, or if you're on Medi-Cal, that's IHSS. So we deal with basically three levels of homes. There's large assisted living or retirement, and that's like Regency Park, Astoria, for instance, or Pasadena Highlands in Pasadena. So those are larger assisted living that provide the meals, transport to doctors, activities, and help as needed. Usually they have an entry fee. So that could be anywhere from 1,000 to 2,000 or 3,000 per month. And then they have a monthly fee, and they have a base rate, and then the base rate is plus level of care. So for instance, nowadays in Pasadena, the base rate roughly 35 to 4,500-ish for a private room plus level of care. Obviously, there are places more expensive, but that's kind of the range. So if you need help with medicine, they charge extra. If you need help dressing, they charge extra. If you need help with bathing, they charge extra. So it's basically a la carte. Some places have dementia units. So they have a separate unit for people that, for instance, could wander, like my grandfather. They're usually pretty expensive. Not every place has that, but there's some that have that. Some have the nursing home attached, but there's very few that have that because that's a huge building. So it's mostly assisted living. Some have a dementia units. So large places, 100 people, transport to doctors, activities, and help as needed. And then we're really good with the second level of care. So those are the small residential boarding care homes. And there's hundreds of those. So those are small homes that take 6 people. They have the same licensure through the state as larger assisted living. They just happen to be a house. So you wouldn't even know sometimes that you're next door living to a boarding care. Maybe you'll see the ramps in front, but it's a regular house in a regular neighborhood. And those usually take 6 people. They have 2 full-time staff. They provide 24-hour assistance. And they're usually not a la carte. They're usually all inclusive. So they can help with the dressing, the bathing, the incontinence, the wheelchair. They help out of bed. They can take catheters. They can take colostomies. They can take wanderers like my grandfather. They can take people with Parkinson's. So anything that's custodial care, which is kind of what you and I we can do. Like we can help someone dress. We can help someone bathe. We can help someone out of bed. We don't need to be a nurse to do that. So that's considered custodial care. And so that's what the boarding carers provide is 24-hour custodial care. They range, there's not a lot in Pasadena because the real estate's pretty expensive. But I would say in Pasadena nowadays, probably 6,500 on up to say 9,000 per month for a private room. And then some offer shared, so roughly maybe 5 to 7-ish for a shared room. There are obviously areas that are more affordable. Pasadena is expensive because the real estate's expensive. But those are places that provide 24-hour assistance. That's most of what our business is. Although we help some people find assisted living, usually we're getting referrals for people that need care. And if you need a bunch of care, the boarding care are usually more appropriate than a larger setting because the larger settings might have one staff to 20 to 30 people during the day and one staff to 30 to 40 at night. Now they don't turn away people. So if you call a large place like Regency Park and say, oh, Dad needs help dressing, he needs help bathing, he's incontinent, they'll say no problem, maximum assistance. But we tell families you really have to look at the staff to resident ratios because large places really aren't equipped for someone that needs a ton of help. Although they don't tell you that. We think the boarding care homes are much more appropriate. Although the boarding care homes are much more boring because larger places have activities, group dining rooms, a lot of socializations. Boarding camps don't really have that. They, for the most part, provide really good care, but it's not like they have a full-time activity director. And I tell families they're boring, but your dad who needs help dressing, bathing, incontinent, wheelchair, dementia will get much better care, I think, at a good boarding care. Not every boarding care is good, but a good boarding care than a larger assisted living. And sometimes families say, well, but do they have activities? And we say, okay, what does your dad do for activities? But you just said your dad is very confused. and he needs a lot of physical help. So sometimes families are focusing on what they want, but they're not really looking at the care needs of their relative. And so we tell families there's two routes to go, but yeah, dad will have more activities in a large place, but there's not going to be as good of care because care is oftentimes determined by staff to resident ratio, and large places don't have a great ratio. And then the small boring care homes have a really good ratio, one staff to three people, but they're boring. So those are the two options. My grandfather wandered. All the activities in the world wouldn't have really mattered. They had activities, but he just went in the backyard and sort of wandered back and forth. They took him for a walk. He wasn't really capable of doing a lot. So even when they brought in activities, he wasn't really focusing on that. The board care worked out well for us. The first board care, like I mentioned earlier, was a nightmare because he wasn't on the right medicine. He was like a human guinea pig. Oh, he's aggressive. Let's try this medicine. Oh, that didn't work. Okay, let's try this medicine. Meanwhile, the staff and the residents are suffering because he's a human guinea pig in a setting where the staff have to bear the consequences. That's why geriatric psychiatric units are good options for people that are out of control, because that's a neutral setting where someone can go for a few weeks. Medicare pays for it, and they can work on the medicine, start from scratch, see if that medicine is working. If it doesn't work, start over again. But at least when my grandfather was discharged from the second geriatric psychiatric unit, he was placeable and he was in aborted care for 5 years. So we put him in two geropsych units. And so we get calls from families, like really interesting stories. This one the other day was for this wife looking for her husband, pretty confused, but kind of aggressive. And she's like, he cannot live with me, but he doesn't want to leave the house. And so they managed to put him in the hospital. But she was really concerned because he could wander. And this one home we recommended was actually close to where she lived. And she's like, I don't think they would be equipped, because if he wants to get out, he's going to get out. Because boarding care homes, there's these nice staff, but they're not going to barricade themselves in front of a door and say, you cannot get out. Most wanderers aren't that physically aggressive, and most aren't that conniving that they're going to wait for a jail break, like someone's back is turned and they're going to try to wander out. But in this case, she had to put him in a geropsych unit, and she went with a larger dementia unit, even though she didn't really feel he needed all the activities, but she wanted a place that was more secured, because they have devices like doors you have to press on for a minute or so before they open. They have better water guard systems. They have bracelets. And so there are advantages for the dementia units for someone, for instance, who could wander, but they're also usually quite expensive. So that was one interesting case we had. We had some other cases where people were psychiatric. And this will tie into when I get into a little bit about Medi-Cal and the type of clients who are being referred. But we don't really deal with psychiatric placements. We mostly deal with boarding care and assisted living who are for the elderly. So usually 65 and older, some exceptions. But someone who's like schizophrenic as a primary diagnosis, we've confirmed this a lot of times with licensings, they're not really allowed in a boarding care or assisted living because they're not psychiatric settings and they don't have any experience with that. Now, if someone has dementia and needs help dressing, bathing, and maybe a secondary diagnosis, that might be different. But we've had a few calls lately for people that were schizophrenic, and we can refer them to the Department of Mental Health. There honestly aren't a lot of good resources for people that are psychiatric that even exist now. The state is giving more funding, it's trying to get more funding to galvanize that, but it's really hard to place someone who's psychiatric nowadays in California. There's just really aren't great settings. You have adult residential, which are usually for younger people, 18 to 59. They sometimes can take psych, developmentally disabled people, but there is a huge issue if you happen to be elderly and say you're schizophrenic. So we're not very good with that. So I mentioned 3 levels of care. The last level is nursing. We don't really deal with nursing. We get a lot of calls for people asking for nursing, but it's very hard for us to track the quality of nursing homes. They have sometimes 100% staff turnover rate. Licensing always comes in. There are good state resources. If you go to medicare.gov, there's a way that you can get a rating system. of the nursing homes. But it's very hard to track the quality of nursing. And the vast majority of people that are actually in nursing, I believe, do not need to be in nursing. They have the same exact care needs as people in boarding care: dressing, bathing, incontinence, wheelchair, Alzheimer's, Parkinson's. But a lot of times people end up in nursing homes because they're low income, or families don't know. When families call us and say, oh, dad needs help dressing, bathing, incontinent, wheelchair, he needs a nursing home, then we describe the different options. Well, you just said your dad needs help dressing, bathing. He doesn't have a G tube. He doesn't have an IV. He doesn't have a tracheostomy. He doesn't really need nursing. Now, sometimes family insists, so we give them resources. And the other time is a lot of times they don't have money for a boarding care. So, but I would say over my 35 plus years of doing this, I would say easily, if you were to ask me, at least 75% of people in nursing homes do not need to be in nursing. They have the same exact care needs as people that we place in boarding care, which is really interesting because the state spends about $7,000 per month for someone on Medi-Cal in a nursing home. So when you think about all this money that the state's spending for all these people that don't need to be nursing, that translates to literally millions of dollars a year. So that'll be my segue into our public policy and one reason why Wayne invited me to speak about these interesting programs. But before I go into that, any questions about the different levels of homes, how much they're priced, any questions, in regards to those settings that you might have?
Yeah, just go ahead and unmute yourself and ask your question.
The question that I have, and maybe you mentioned this and I missed it. What is, say in the Pasadena area, what is kind of the range of monthly expense for being in a care home?
So the assisted living, sometimes they have entry fees, so that could be 1,000 to 3,000 per month.
Oh, yes. Okay, I remember you saying that.
The base rate for assisted living roughly is about 35 to maybe 5-ish plus level of care. So level of care could be medicine, 400 extra, dressing extra, bathing extra. So they're usually a la carte. The boarding care, they're not usually a la carte. And so I would say nowadays in Pasadena, the range is maybe 65 on up to 9 for boarding care. Now those rates are pretty high. And we always tell families, well, are you willing to travel? Because Glendale's more affordable, the Valley's much more affordable. So like for instance, in the Valley where there's tons of homes, tons of good homes in North Hollywood, the range for privates for boarding care is now roughly, I would say 55 to 65. That opens a ton of homes in the Valley, which is much more affordable than homes in Pasadena. It just means you have to travel. So the price of the homes is usually dependent on real estate and other factors. And there's not a lot of homes in Pasadena. Like in Pasadena altogether, there might be maybe 20 boarding care, but in North Hollywood, there's like 40. And then in Reseda, there's 40. And then in Van Nuys. So in the Valley, you have hundreds of homes. Why? Because the real estate's more affordable to open up homes. And so, but the prices are going up. It's really interesting that we placed my grandfather in a home many years ago for $1,500 per month, which was a shared room. And he had the money, so we were able to tap into his money to pay for the home. But nowadays, like that does not exist. And honestly, even if you had 2,000 per month, you could not afford a shared room in a boarding care, even if you had 2,500. So because of labor laws and because of real estate and because of minimum wage and because of all this stuff, real estate's going up and up and up. It's becoming really expensive to operate a home, but it's also becoming really expensive for people to go with like a boarding care. And, I found over the years that, not everybody has planned very well for what happens if dad needs care or mom needs care. And so they're kind of stuck. And the other issue is, I'll just mention nursing homes. you know, if there were great nursing homes that always took Medi-Cal, life would be beautiful, but it doesn't really work that way. To try to find a Medi-Cal bed coming from the community is really difficult in a nursing, because what they really want is someone going to the hospital, being there for 3 days. Medicare pays after 3 days, and say they need rehab and they go to a nursing home for rehab. The nursing home gets paid twice as much for that person that Medicare is billing for rehab than they get for a Medi-Cal person. So nursing homes really want the high-paying Medicare people, but they don't want the lower-paying Medi-Cal people. Although, interestingly enough, I did say that Medi-Cal pays about $7,000 per month, but Medicare is paying twice that. So the other problem is when we get a call from a family saying, oh, you know, we don't have any money, you know, dad needs a lot of help dressing and bathing, and incontinent in a wheelchair. And we say, well, you know, there are nursing homes, but it's going to be very difficult. Here's where you get a list of the nursing homes, look at the ratings, call nursing home after nursing home, but the problem you're going to find is they're not going to want to take someone Medi-Cal from the street. They'd rather take that person coming from the hospital when Medicare pays twice as much. So that's also very difficult, let alone the quality standard of nursing. But it's really tough if you're low income and you need care and you can't live at home. I mean, it's very tough. So let me go into a little bit now about the public policy.
Oh, I think Bruce has a question
Sure.
too, Jason.
Hey, Bruce.
Oh yeah, I see his hand raised.
Yeah, I had my mom in an assisted living for 4 years. It was a self-pay and it was not in Pasadena area. So that worked out. She had some long-term care insurance and things. In my observation with the village, I think we have quite a few people who may not have like long-term care insurance, but they do own a house in Pasadena. And so I guess the way I'm thinking about it, do you help analyze, or can you refer someone to somebody who can help analyze? So say someone has a home, and in Pasadena, those are fairly expensive. They need assisted living. And so they sell that home, and that will keep them taken care of for X period of time. And then they run out of money. And then what's the natural progression to go to Medi-Cal and stuff? So do you offer kind of an analysis and advice? Because, you know, I think we have people in all situations in the village, but I think it's a fairly common one where we have people who have, say, Social Security and possibly a pension and a home. But I was over at Kensington a year or so ago, and it was $12,000 a month. And that's pretty stiff. But if you have $1 million house, you know, that does cover you for a while. So do you guys offer that, or do you have referral people who can do some analysis for a family?
I mean, we are not experts on that about, you know, if you sell your house, you're going to get $1 million. Obviously, they can get quotes from realtors. I mean, what we can do is, you know, say someone says, well, I have a reverse mortgage and I have 100,000 left in my house. And we can say, well, in Pasadena, you know, based on what you're describing, based on the care needs, you're probably looking at roughly 6,000 per month times 12. So times how many years you're thinking. And so, sure, I mean, on the back of an envelope, we can give some advice, but obviously for more sophisticated, that's a financial planner, you know, a realtor. But we know the rough ideas for the rates of the home. And when we call the homes, what happens is when we get a referral, we call the home and say, okay, based on this care need, what do you think you want to charge? So as long as the care needs are accurate, we can get back to the family. And when we send them the list, we usually send like 5 to 7 ideas, usually within about 2 hours, and say, these are the homes that have openings. This is the rough range of the homes. But I want to answer your question about the Medi-Cal part, which is the part that I'm really interested. Any other questions just related to that?
We have somebody's hand up.
Yeah, I just wanted to get a clarification, Jason, on the Medi-Cal bed. What about a Medi-Cal situation where there's a share of costs? Does that improve your odds at all, or is that still a rarity?
let me take the other questions because I'll go into deep dive about Medi-Cal in a second, but I don't know if there's any other questions.
I think Miss Vic has a question.
Yeah, I do. Just quickly, you mentioned cheaper places in the valley. What about east, like Redlands or, just further east of Sierra Madre and Pasadena and Laverne? I mean, those areas, are there any assisted
I would
living homes
say-
that are cheaper?
I would say, I mean, obviously not Pasadena. So if you go into other
Right.
areas, that aren't maybe where there's as limited homes, it starts opening up West Covina, Azusa, Diamond Bar.
Mhm.
But I would say roughly the average nowadays throughout LA, not the most expensive areas, is again for a private room in assisted living, roughly 35 to 45 days plus level of care. In a boarding care, roughly 55 to 65, roughly. So that's kind of all throughout LA. And curiously enough, even if you go to Riverside and San Bernardino, it isn't much cheaper than that. So
Wow.
those are, but I would say if someone was in, like my grandfather, he lived in West LA. We could not afford West LA. We didn't mind going to the Valley. We had to place him, and we placed him in Northridge at this more affordable home. It was kind of a pain in the butt to travel, but we didn't have the money to afford a home on the west side. And that's an option families obviously have, that, if you're willing to travel, we could find. But the problem is that, say you haven't saved well and you don't get a lot from retirement or Social Security. Nowadays, good luck trying to find any home that's, below 3. And even nowadays, like 3 is possible for like a shared room and a boarding care. But that keeps on creeping up year after year. So, but then let me segue into the Medi-Cal because that's sort of the cool topic that I like.
Let's just
So- Oh,
really quick, just check and see if there are any other hands up. And of course, a lot of people don't have their cameras on. So if you're raising your hand and you don't have your camera on, can't see them. So anyway, okay, go ahead, Jason.
all right. So here's a question that Bruce had. What do you do at some point if you don't have money or you run out of money? And this is an issue that literally every other call that we get for 35 years is this scenario. Same exact care needs as someone who has money, dressing, bathing, wheelchair, incontinent. We can help that person. Next person to call, same exact care needs. Dad only gets Social Security. Well, how much does dad get? Dad only gets $1,200 per month. Are there any assets? No. Can the family help supplement him? No. But dad can't live at home because, we can't take care of him, or mom's taking care of him and she's burning out. What do we do? So California started one program, I think about 10 years ago, called the California Assisted Living Waiver. And I mentioned earlier that my friend and I, the associate director for the American Parkinson's Association, we went up to Sacramento, we helped draft a bill, we met senators, SB 353. Our bill didn't pass, but at the same time this other bill passed. It was AB 499, and out of that was something called the California Assisted Living Waiver. And the California Assisted Living Waiver is called a waiver program because when Medi-Cal can pay for things other than nursing, the state applies for something through the Center for Medicare and Medicaid Services for a waiver. So it's, instead of paying for nursing, this waiver is going to allow Medi-Cal to pay for something else. So that's called a Medi-Cal waiver program. IHSS that I mentioned earlier, in-home support and services where people can come in, is one type of waiver program. PACE, you might have heard of, is another type of waiver program. So these are all programs that allow Medi-Cal to pay for something other than nursing, because the state realizes that nursing homes are really expensive for people that don't need to be in nursing, although they haven't been very aggressive up to this point, keeping people out of nursing. But the assisted living waiver program was generated, and that's a program that the state developed, and it does allow Medi-Cal to pay for assisted living. They have limited slots though. So I think that capacity now, I think it's either 12,000 or 18,000, which they quickly filled up over the years. Every year, I think they try to apply for more spots. But that's a waiver program where they have a certain number of slots. And they, when they go over it, they have a wait list. So Wayne and I were speaking before some people got on, that for nursing home diversion, the wait list could be 8 months to a year or longer, because now they have about 3,500 people on the wait list. For nursing home transition, so say you're in a nursing home for 2 months and you're long-term Medi-Cal, that's considered nursing home transition, right? You're coming from nursing, going into the community, as opposed to nursing home diversion, which is someone calling us saying, Dad doesn't want to go to nursing, we don't know what to do. He's in the community, and you're trying to divert that person, not going to nursing, going to something else. That's called nursing home diversion. So for the assisted living waiver for nursing home transition, basically, if you're in a long-term Medi-Cal for 2 months, you go to the top of the wait list. But for nursing home diversion, that wait could be 8 months to a year or longer. And why is that? Because if you're in a nursing home and the state's spending $7,000 per month, and you go to a community-based setting, remember earlier I said the rough cost for like a boarding care is roughly 35 to 4. That's roughly the cost, half the cost of a nursing home through Medi-Cal. So for every person who transfers from a nursing who goes to a boarding care, you're saving about $30,000 a year. That's a lot. That's just for one person. So the reason the state has a priority for nursing home transition is you're actually saving money, right? Because they have fixed costs. We're paying $7,000 per month. That person's going to boarding care. The state saves money. Good deal. But nursing home diversion, when you think about it, not everybody is using Medi-Cal resources. Like not everybody gets IHSS. Not everybody's on PACE. So those are usually new dollars, right? Because if someone calls me and says, Dad's at home, he needs a lot of help, he gets $1,200 per month, what do we do? For nursing home diversion, that person might not really be costing the state that much money for Medi-Cal because maybe they don't get IHSS. And those are new dollars. So that's new dollars that the state is spending that they weren't spending before. And the state's very afraid of something called the woodwork effect. The woodwork effect is you throw out this benefit to a lot of people, they hear about it, and suddenly everybody's coming out of the woodwork trying to take advantage of a program that you end up costing the state more money than saving the state money. And that's why for nursing home diversion, they have a long wait list, because the priority is nursing home transition. And for every 1 or 2 people that do transition, that opens up some spaces for nursing home diversion, because they kind of want the program to be cost neutral, save money and be cost neutral. But remember, for nursing diversion, that's new dollars. For nursing transition, that's saving money. So they're kind of setting up the program to be roughly cost neutral. So the assisted living waiver, the way that it works is they have 5 levels of care. So the care coordinator agencies for the assisted living waiver program, and we applied to become one. So hopefully within a month or so, we'll get approved. But you call a care coordinator and you say, I heard about the assisted living waiver. And so the first criteria, that person has to be what's considered nursing home eligible. It's not a housing program. It's a program for people that are at risk of premature institutionalization, that the state says, yeah, this person really needs nursing. He doesn't really need to go to nursing, but he needs too much care to stay at home. So in other words, that person needs to have substantial care needs. It's not just for someone like, oh, Dad's fine, but he can't afford his rent. That's not what the program's for. The program is for Dad's at risk of being prematurely institutionalized. So that's the first criteria. You send an RN to do the assessment, different tiered level. Tier level 1, roughly $80 a day. Tier level 2, roughly $100 per day. Tier level 3, $110 per day. So that's what Medi-Cal pays for their assisted living portion. And the person or the family is responsible for the room and board portion. So those 2 portions. The room and board portion is roughly $1,300. So for someone who gets less than that, who paid into the system, SSI bumps you up, Social Security supplemental income, bumps you up to about $1,500 per month if you go to boarding care. So again, say someone, Dad only gets $400 per month. That's all he gets. He has no savings. He has no assets. Did your dad pay into the Social Security system? Yes, of course he worked. So if Dad is eligible for Social Security, because not everybody is, sometimes people never paid into the system, then the minimum of Social Security kicks up for a boarding care or assisted living is roughly 1534, something like that. Of that portion, the person gets back about 200. And then they pay the difference as the room and board for the assisted living waiver. So roughly the boarding care or assisted living gets 13. And then Medi-Cal through the state, based on that tier level of care, pays their portion. So say someone's tier level 1, we'll say $80 per day. $2,400 per month is what Medi-Cal is paying, plus that person's contribution, which is roughly $1,300. So that's roughly $3,700 per month, which does open up market rate for boarding care or assisted living. Now, maybe not a private room, right? Because the private rooms in a boarding care, nowadays 55 to 65, but a shared room, because, if you go to nursing, it's not like you get a private room in Medi-Cal anyway. So that's how the assisted living waiver works. So you have an RN that goes out to do the assessment. Is that person nursing home diversion? Is that person nursing home transition? If they're nursing home transition, they have to be in the nursing home for 2 months on long-term Medi-Cal. So as people go to nursing home and Medicare is paying for rehab, those days don't count. That person has to actually convert over to long-term Medi-Cal before they're eligible for the assisted living waiver, and they have to be there for 2 months. For nursing home diversion, the care coordinated agencies will take the intake, but they just basically put that person on a list because they have a long wait list for nursing diversion. Every month, I believe what the state does is they release to the care coordinator agencies a certain number of slots to each agency. But depending on where that person is on the wait list, and if they're nursing diversion or a transition, they have their own priorities. Now, curiously enough, there is one workaround that we discovered speaking with care coordinator agencies, is if there's an open APS case, if there's an open adult protective services case, that person now can go to the top of the wait list. So in other words, we tell families, your dad needs help dressing, he needs help bathing, he's incontinent, of course you could go nursing, which is really hard to do. By the way, there is this program called the assisted living waiver, but they have a long wait list. But did you know that, if you call APS and say, I don't know what to do, I'm burning out, I'm taking care of my dad, he needs help dressing, he's starting to wander, so it's not a neglect issue, it's like, I don't know what to do issue. And if APS opens a case, then you call an ALW care coordinator agency, that person can go to the top of the wait list. They don't get immediate placement, but at least they're not buried in that wait list with 3,800 people. So that's kind of a clever backdoor approach that not everybody knows about. So again, that's called the California Assisted Living Waiver. They do nursing home diversion and transition, long wait list. One other thing to mention is that, one, you cannot have what's called a Medi-Cal share of cost. And I think Bruce had asked about that. So say someone gets $2,500 income per month. And say, for instance, they want help with IHSS. They have to actually eliminate their Medi-Cal share of cost or spend privately so that they can get in-home support and services. So that means they have to almost spend down to get below that 1,500 threshold that I mentioned. And I don't mean spend down like, oh, go out and buy a big screen TV every month. There's certain standards that the state has, vision insurance, life care insurance, legitimate expenses that you're basically getting below that threshold, that you're eliminating what's called a Medi-Cal share of cost. So for the assisted living waiver, either you have to eliminate the Medi-Cal share of cost, or according to ALW care coordinating agencies, you're paying a lot more for the room and board portion. So say you say, well, I really want dad to be in a private room, $5,500 per month. The room and board portion, again, is usually just $1,300. But say dad gets $2,500 income per month. If the family slides a lot more towards the room and board, in a way, they've also eliminated the Medi-Cal share of cost. But in other words, you can't just pocket that difference and say, cool, here's our $1,300 for the assisted living waiver. That does not work. You have to eliminate the Medi-Cal share of cost. Now in California, they passed some new laws, actually pretty recently, that they don't really almost care about the assets you have. And so I don't know if you've had talks about that. And I think in January, they got rid of the asset limit entirely or getting close to it. So you could still have 200,000 in assets and apply for Medi-Cal because they're kind of looking at the monthly income. But that was something that the state gradually is passing. There's other standards that they have, but so it's not really an asset determination. It's more of a monthly income determination. So that's the assisted living waiver. So that's one program that's been around forever. Everybody knows about it, long wait list. But let me segue into a new program that the state began 2 years ago that we're now involved with called CalAIM. By the way, any questions out there about the assisted living waiver, Bruce?
Now, I guess what my question is, what terminology would you use? And this is going back to at least my concept. Somebody sells their home, is in assisted living for 4 years. You know, towards the end of that, develops dementia, and they've spent down, and they have, you know, X amount of retirement. Is that terminology going into Medi-Cal supported facilities a different path? Because you've talked to a lot of people going in for the first time. This is, at least I'm envisioning somebody being in care for years. As with my mother, she went in driving, managing her medication, but within a few months, she had dementia and was 4 more years with dementia. So going from self-funding for X number of years to Medi-Cal, what's the terminology there?
So I should have mentioned that for the assisted living waiver, every home has to be registered with the state and they have to be Medi-Cal certified, which is a process that could take 1 to 2 years. Most homes do not work with the assisted living waiver. So the home, for instance, that your mother was at, most likely they weren't working with the ALW program.
No.
Because a lot of times private paid homes are like, we have no problem being filled. Why do we need to, get X amount, which might even be less than we get for a private paid person? And for the assisted living waiver, normally if you're private paid and you go to a home, you pay up front. But for the assisted living waiver, they can only bill after services have been rendered, which means they can only bill 30 days and they might have to wait another 30 days before they actually get paid or longer. And not a lot of assisted living want to do that. They don't want to wait 60 days to get paid. So I should mention that the assisted living waiver, they have homes that work with the program, but I would say it's maybe in LA, maybe 1/5 of all the homes work with the assisted living waiver. And we've encountered, because I'll segue into the new program where we're kind of team tagging on ALW. A lot of the ALW homes are pretty substandard. Why? Because they're like, oh, we can get a higher rate than we were getting for this private pay person. We're only going to take ALW. And when you look at their violations, a lot of them are more substandard than private paid competitors because they're willing to work with ALW. Not that the rates aren't fair, but when we go down the list, you see a lot of homes that aren't the greatest. So to answer your question about if someone's segueing for this one program and then a new program that I'm going to talk about, if that home doesn't work with those programs, that person has to leave because that home isn't working with that program. The other thing is someone could spend down, not have any more assets, but they might still get $3,000 per month from Social Security. And then remember, for ALW, they really have to figure out how to either pay more for the room and board portion or really get below that Medi-Cal share cost threshold.
Okay.
And I think
Yeah.
there's another question.
Yeah, we've got Jocelyn and Vicky.
Jocelyn?
I was just wondering, you've referenced a PACE a couple of times. I don't know what PACE is.
Right.
PACE, for the most part, is a program that helps people stay at home, although there are some derivations, but it usually is you're signing over, maybe Wayne can confirm this, but you're signing over your sort of Medicare and Medi-Cal to this agency that manages everything. So you have to go to their doctors, they send out nurses, they help you stay at home. So that's what the PACE program is. So that is a Medi-Cal waiver program.
Thank you.
Basically it.
Okay, so what I want to know, you said for someone to be eligible to be considered for the California Assisted Living Waiver, they have to be nursing home eligible. Well,
Eligible,
suppose
right? Yeah.
eligible, but suppose they're not, they aren't incontinent. You know, they can bathe and dress, but there's just their dementia has gotten worse. That's my situation. I'm caring for someone with dementia. And it's cognitive and her memory is just getting worse and she's getting more and more confused. So what happens when her money runs out? What is she eligible for?
We're not a care coordinator for ALW, but I believe over the years that sure, if you have dementia, that's someone who's at risk of premature institutionalization. I don't think there's a standard that it has to be physical. There just has to be a high enough standard that that person's assessed at a certain tiered level, and it's not a program for housing. So, you know, in our business, we're placing people that physically are good, but are completely confused. And I don't think that's going to be an issue for the LW program.
Okay,
Again, we're not a care coordinator agency. We're going to become one. We applied 8 months ago. They have low staff. They're looking at our application. But eventually, in the next month or so, we'll have more detailed knowledge.
but you're saying she might be eligible for the California Assisted Living Waiver
Yeah,
because of the cognitive thing.
right. If it's mild cognitive impairment, oh, dad's a little bit confused. We can't take care of him. How's he physically? Oh, he's completely fine. Then yeah, that might be like you're on the edge because that person isn't really considered skilled nursing. Anyway, they have their threshold. They have actually an input tool that they put in all the care needs and then they get spit out the tiered level. We don't have access to that tool.
Okay.
So we call them a lot because we get a lot of people that we're referring to LW care coordinator agencies that at some point we're like, why don't we just become one ourselves? Because we're referring a lot of people.
And then in terms of APS, can you say I'm at my wit's end? I don't know if I'm going to hurt this person, or should you not even use the word hurt? You just want to let them know you're stressed out and you just don't know what you might do tomorrow. You just can't take it anymore. And would that be a case that they would open that might put you, you know, at the top of the heap?
Yeah. I mean, I'm not APS and APS doesn't work with ALW. I'm just saying that certainly sounds like a valid reason to call APS. Now, I don't know what standards they have, like, oh, we're not going to open up a case, you're burning out. I don't think so. But, you know, that's really individual basis. But that's a trick that we've learned. But, you know, what their standards are for saying we're not going to open up a case, I don't know. But I think it's always worth a try, saying I'm burning out, mom's wandering, I don't know what to do, I really need your help. So as long as they open up a case, then you call an ELW care coordinator agency and say, you know, hey, we want to apply for the program. By the way, we have an open APS case, you know, and then they'll also be able to, you know, okay, tell me about your dad's care needs. What are the care? So they can help you with that. So more questions about that, because I'm going to segue into another program that's similar, and that's the new program.
Any other hands? If your camera is not on, just unmute yourself and speak up.
Well, yeah, you can raise your hand if your camera's off and you will come up in the list of raised hands. At least that's my
Some
experience.
people might not know how to raise their hand.
I put the instructions in the chat for all the different devices.
Okay, good.
All right, so let me share a screen. So I'll talk a little bit. There's a new program that the state began called CalAIM, California Advancing Innovating Medi-Cal. And let me see if I can share this screen. So you guys see that?
Yeah, it's up.
Okay.
We see it in editing mode. There
Okay.
you go.
There you
Okay.
go.
All right, so CalAIM is a program that the state began a few years ago, and it's another method to allow Medi-Cal to pay for assisted living, but they have many components. And so we actually are now contracted with HealthNet and Kaiser an Inland Empire Health Plan to be a community support provider for CalAIM for nursing home diversion transition to assisted living. Now, this slideshow we made about the IEHP program, but this is relevant to all the managed care that we now are contracted with. And so CalAIM, this is the presentation that we made to different hospitals, but what we do, and we've written a lot of public policy articles. We speak a lot of conferences, but now we're contracted with HealthNet and Kaiser for this program. And what is CalAIM? Well, the state realized that over the years, people going to nursing home who don't need it are really expensive. So over the years, states now have tried to spend less money for institutional care and more money for home and community-based services. So that would be IHSS, that would be Medi-Cal paying for assisted living. But in other words, the state realizes that they have to have cost control and they have to stop people going to nursing who don't need it. So that graph shows over the years, less money for institutional care, more money for home and community-based services. So CalAIM began a few years ago. It's a 5-year program, $3 billion to transform the Medi-Cal system and to integrate it more with other social services programs. And they want to leverage the vulnerable populations, people that are homeless, children with complex health needs, justice-involved populations. Those are people in jail that are getting out, that need care, and the aged, and dual eligible integration. So people on Medi, they're called dual eligibles. Medicare, Medi-Cal, those are called dual eligibles. And dual eligibles cost the state a lot of money because they're elderly and they're low income. So as opposed to people that aren't on Medi-Cal, that are just elderly, dual eligibles cost the state a lot more because they are elderly and low income. So CalAIM began, I think 2 years ago now. And so there's many different components for CalAIM. So basically, they're trying to identify the people that could benefit from the systematic organization so that everybody's being funneled through managed care plans for people that are on Medi-Cal and with good outcomes. So it's for people that children and families, for adults, people with disability. And so what the state is trying to do is use a whole person care approach to improve quality outcomes, to create a consistent and efficient Medi-Cal system. Because right now, Medi-Cal is very disjointed. One service pays for something, another service pays for something else. They don't really talk to each other. Medicare people are using that, but Medicare isn't really integrated well with Medi-Cal. So this is the state's goal, that they want to start integrating all of these different Medi-Cal pathways to become more seamless by going through managed care plans. So now they're enrolling dual eligibles in the state with managed care plans. So the reason they're doing this is because the Center for Medicare and Medicaid Services, CMS, basically gave a new definitions to the states that now they can use something called in lieu of service. So in lieu of going to nursing or ILOS, we will allow the state to have creative ideas to use Medi-Cal, not just through waiver programs, but use Medi-Cal to pay for settings other than nursing for people that are considered nursing home eligible. And so the point is to combine social and Medi-Cal determinants of health to avoid a higher level of care and to stop people going to nursing homes unnecessarily or emergency rooms unnecessarily, or people stranded in hospitals. We don't know what to do. This person can't go back home and they're just stranded. So these are all people that cost the system money, but the state didn't have a very elegant way of combining all these Medi-Cal programs. And that's what they're attempting to do through CalAIM. And so there are many different, these are called community supports. So in lieu of service in California, that the nationwide is called in lieu of service, but in California, they're called community supports. So the state is rolling out these community supports to help people stay out of nursing, to help them avoid hospitalization as necessarily people stranded in emergency rooms. And then the other part that the state began with CalAIM, by the way, CalAIM is California Advancing and Innovating Medi-Cal. That's why it's called CalAIM. So there's two parts of CalAIM. One is the community support, and one's called enhanced care management. And enhanced care managements are people that really require a lot of sort of hand-holding, that the state wants to implement new benefits to work with this person. Why, can that person stay at home? So it's really enhanced care management, a lot of times to allow people to stay at home that really need a lot of connectiveness. What are services we can help you with to stay at home? So that's called an enhanced care management. So an improved care coordination, improved integrating services, improved health outcomes. So there's two parts. So CalAIM has the community supports, and they have enhanced care management. So those are the two parts of CalAIM. So for community supports, there's 14 different components. One is the housing transition navigation services. So those are people that say they're in a nursing. Well, actually, that's for more homeless people. So there's a lot of people that are homeless because they can't pay rent, they don't know where to go, they don't know what services to find. So that's one component. Housing deposits, like through this program, they'll pay at least the deposit. How to, people that are at risk of losing their housing, that need care. This is helping those people stay at home. Do you need, grab bars in the bathroom or wheelchair accessible? So those are housing tenancy and sustaining services. Another component, post-hospitalization housing for someone that can go home, but they need a place temporarily. Recuperative care, respite services, a bunch of programs. One is helping people transition from a nursing home back to their home. Say they still have a home. Again, wheelchair accessible bathrooms, ramps. How do you allow that person to go back home? Other homemaker services similar to IHSS, environmental adaptations. People sometimes just need meals. I can't cook. I don't want to cook. Well, that person doesn't need to go to a place. They just need meals arranged. Sobering centers for people that are alcoholic. And then our component, which is the nursing diversion transition to assisted living. So again, CalAIM has two parts. One's the community supports, which in the nation is called in lieu of service. In lieu of going to nursing, these are services to allow people not to go to nursing, to stay in the community, called community supports, and enhanced care management. What are all the services we can offer this person so that they don't really end up in nursing? They just need better connectedness with hospitals, with rehab, with social services. And then for the community support, there's 14 of them. And so many different components. Our component is the nursing home diversion transition to assisted living. So for eligibility, again, this is for IHP, but this applies to every managed care plan. By the way, I did mention that every managed care plan for these community supports doesn't have to offer all of them. So see where it says CalAIM plans can pick which of the in lieu of service or community support they would like to offer their members. So Kaiser, for instance, might not offer all these 14 community supports, or Molina might not offer all of them, or IHP. They can pick and choose which ones they want to offer. But for the purpose of our component, nursing home diversion transition to, by the way, RCFE is residential care for the elderly. In California, they call assisted living or boarding care RCFEs, residential care for the elderly, but no one knows that, but that's what they're called. So that's why we say large places assisted living and small places are boarding care, but the state calls them RCFE, so it's just easier to abbreviate. RCFE is either large assisted living or small boarding care. So for the community support, I mentioned earlier that assisted living waiver has certain criteria. The community support for nursing home transition has the same exact criteria. You have to be in the nursing home on long-term Medi-Cal for at least 60 days. You have to be willing to live in an RCFE. So this can't be forced upon someone. It would be Mr. Johnson, for your dad who's in a nursing. Maybe he doesn't need nursing because he doesn't have an IV, he doesn't have a G-tube, he doesn't have a tracheostomy. Would you like him to be considered for this new program. But dad might say, I love the nursing. I know everybody. I don't want to move. So he has to be willing to be part of this program. And then obviously he has to be safe, because obviously there are people in nursing that need nursing, IVs, G tubes, tracheostomies, someone who very fragile, always getting skin wounds. They really need a nurse to be there all the time. Like, they have to have a nurse. So again, this program is not for people that really, truly, honestly, really need to be in nursing. These are for people that have custodial care that don't need nursing, that could live in a boarding care where they provide 24-hour custodial care. And then for nursing home diversion criteria, again, they have to be interested in living in the community. They have to be willing and safely able to reside in RCFE. Again, that's assisted living or boarding care. And they have to be, like the assisted living waiver, the minimum level of care. So for assisted living waiver, they have their own criteria. We actually are developing our own criteria, because HealthNet, we're contracted now with HealthNet for this community support, and Kaiser. Okay, Kaiser hasn't started their program yet. We're still working with them. We have a meeting tomorrow with them. They started their program in January, but HealthNet started their program 2 years ago. So right now for the HealthNet, we just began the program, and we actually just placed one person through the program, and now we're working on 2 or 3 others. But it's a very new program. And so Kaiser hasn't started their program yet. And LA Care started their program. We honestly have no idea what they're doing for their program, even though for 2 months we've asked them, hey, we get a lot of calls for people that have LA Care. We'd like to work together with you because, HealthNet is in LA and we don't need to reinvent the wheel. And honestly, even though I've contacted LA Care like 10 times, I've never gotten a straight answer how their program is being developed, because it would be nice to know what components they're following. So for instance, for HealthNet thought it was just easier with our advice to copy the ALW rate tables. So remember I mentioned earlier for ALW, they have the 5 different rate categories. They have an RN that does the assessment. They have a social worker that goes out once a month to make sure the person's happy. Basically, the HealthNet said, we're just going to copy all those components, which makes life really easy, because when we eventually become an ALW care coordinator agency, both programs will have the same standards. But there are some differences. For instance, for the community support, that person is allowed to have a Medi-Cal share of cost. So remember I mentioned earlier with ALW, say someone gets $2,500 income per month and they have to spend down to get below that threshold, or spend a lot more for the room and board. And we've asked HealthNet this, like, how do you want to do it? And they're like, we only want to pay our tiered level. So that Medi-Cal level, tiered 1 through 5. We don't care, and the state doesn't mind if that person has a Medi-Cal share of cost, which is kind of interesting, which means, say that person calls us and dad needs some dressing, dad needs some bathing, dad's incontinent. What do we do? Well, hey, you have the assisted living waiver, they have a long wait list, or now you have this community support. What is your managed care plan? And they'll say, well, LA Care. And they will say, call LA Care and ask what they're doing for this community support. But do you have HealthNet? Oh, yeah, we have HealthNet. Oh, let us tell you about our program. And so if that person gets $2,500 income per month, HealthNet is only requiring that person to only pay that $1,300 for room and board. Remember, if they get less than $1,500, they get bumped up to that. They just require that person to pay the $1,300. Say they get $2,500, they can actually literally pocket the $1,200 in their pocket, pay the room and board portion, and Medi-Cal through the HMO pays their tiered level because they're copying ALW, right? So not every HMO is doing that, but that's kind of cool, and maybe not cool, but it's cool. So that person's only responsibility is paying that $1,300 per month. And I'll go over that again because I know that's a bit confusing. Let me just finish this. So the managed care plan pays their assisted living portion. And for IHP, although this is changing, by the way, IHP is Inland Empire Health Plan, but this is HealthNet as well. They're matched in the LW rate tables. The member is responsible for paying the room and board portion, usually through SSI or SSD. And then I mentioned earlier that the bump up rate, actually I have to put 2024 because it's a bit higher, but for 2024, 1492. And so they get back 168 and then they pay the home the 1324. Although those numbers changed a little bit in 2024. So I mentioned there's the ALW program and there's community support. They are different waiver programs. What's very exciting about the community support, the nitty gritty, is we've been going back to the state because we've had an issue. We've said it's easier for the managed care plans because the way that CalAIM works is the state is basically shifting all of the responsibility for these Medi-Cal services to a managed care plan. So literally everybody in LA who has Medi-Cal has been assigned to a managed care plan. Now they can switch. LA Care has a large chunk of the market. You have HealthNet, you have other groups. And so what we've noticed is that the managed care plans for this component would always like to use the assisted living waiver for nursing home transition because they don't have to do anything. They just say, call an ALW care coordinator. They'll do everything, right? It's just easier because that criteria for the community support, if you recall, for nursing home transition is exactly the same. Person has to be in long-term Medi-Cal for 2 months. Obviously they have to be willing to go to an assisted living. Same criteria, but the managed care plans would rather shift everybody. Instead of using the community support, they'd rather use ALW for nursing home transition. Now for nursing home diversion, that doesn't work, right? Because ALW, with their limited slots, has 3,500 people on the wait list. So we pointed out to the state that if the managed care plans, CalAIM managed care plans, are really only using this community support for nursing home diversion, because ALW has a huge wait list, but not for nursing home transition, it's going to be hard to establish cost neutrality, right? Because remember I said earlier, for nursing home diversion, it's usually new Medi-Cal dollars that haven't been spent. For nursing home transition, it's usually saving money. But if the managed care plans are only using the community support for nursing home diversion, because for nursing home transition, they're not even using the community support. They're basically sending that person over to the care coordinator for ALW, where the Medi-Cal is paid directly by the state to the home. But for the community support, the managed care plan pays out of pocket and they get reimbursed annually. So when you think about it, remember I said ALW, the different tiered levels? So tier level 1 is say $80 a day, $2,400 per month. That means the managed care plan out of their pocket is paying $2,400 times 12, which is a lot of money, like $40,000. They get reimbursed, but they might not want to pay out of their pocket that much money because it's just easier to tell that person, go through ALW, they'll take care of you. We're not going to go through the community support. But again, the problem that the state has is that for the community support to really work, you have to be somewhat cost neutral. And so we've said to the state over and over again, we have a really good relationship with the state, and we actually have a meeting with them next week because we've asked them for 2 years. You have said that you're going to give fiscal incentives to the managed care plans to promote the community support, including shared Medi-Cal cost savings. In other words, if the managed care plans save you money, we will rebate some of that back to you as a rebate or fiscal incentive. So what happens is when the managed care plans throw their cost into a bucket annually, the state determines the Medi-Cal rate by looking at the total expenditures, dividing it by the number of people covered, and they come up with what's called a capitated rate. Per member per month, we will pay you the managed care plan X amount of dollars, because these are your total expenses divided by the people that are at home, divided by people in assisted living, divided by people in nursing, and we'll come out with that per member per month capitated rate. Well, if you have the shared Medi-Cal cost savings, then the state is throwing into that bucket also these cost savings so that that capitated rate becomes higher, right? Because if they save the state, say that person's in nursing 7,000 per month, and they go to assisted living where now they're saving 3,500 per month, that cost savings per year is about $40,000. So say the state says, that person, we're going to rebate back $10,000 because you've saved us $30,000 because that person was costing us a lot more. That $10,000 goes into that bucket when they figure out the capitated rate. That's a pretty darn good fiscal incentive. The other incentive the state told us, but they haven't publicized it because it doesn't matter if they tell us. If they don't publish it, it doesn't exist. Is they said they'll keep the nursing home rate for 2 to 3 years, even though that person transfers to an assisted living. So in other words, remember that nursing home is being paid $7,000 per month, and if they go to boarding care, now they're say roughly $3,500 per month. The state said, we're going to keep that nursing home rate. We're going to pretend that person is still in a nursing home at $7,000 per month, even though they transfer to a boarding care. And that's an amazing fiscal incentive because now not putting to that bucket 10,000 shared medical cost savings, you're actually putting to that annual bucket $40,000 because they're not assuming that, they're keeping that rate at the nursing home rate. But the problem is the state hasn't published these fiscal incentives. And so even with HealthNet says, Jason, if at all possible, we want you to use ALW for nursing home transition, although you don't have to, but we kind of want you to use ALW. But for nursing home diversion, obviously, community support because there's a huge wait list. But, we're pointing out to the state, again, the problem is you're still not coming up with that cost neutrality. And that's exactly what IHP told us, the Inland Empire Health Plan. We just want you to use ALW, even though the state wants to promote the community support. But the problem is if you're using ALW for both programs, you're really filling up all the slots really quickly, right? Because imagine you have all the ALW people, and now you have all these community support people going into the same program. That doesn't make any sense because the other issue is, remember I mentioned earlier that for ALW, the homes have to become Medi-Cal certified, and there's not a ton of homes that work with the program. For CalAIM, they do not have to be Medi-Cal certified. So we can work with any home that we like and ask, hey, do you want to work with HealthNet for this great program? They pay a fair rate. The only problem is you might have to wait 60 days for the first payment because you can only bill 30 days after, and it takes about 30 days to get processed. Our network is much, much bigger than the ALW network. And so that's another issue we're pointing out to the state. You're saying the homes don't have to be Medi-Cal certified, but you're kind of forcing people to go with ALW homes. And to get a new home into ALW could take 1 to 2 years to become Medi-Cal certified. Anyway, and then for our program, there is no wait list, which is really cool. So nursing home diversion, if someone called me and that person met our standards for nursing home level of care, which might not be exactly ALW, but we've done this for 35 years. So, we're kind of filtering out the people that are like, yeah, that just needs housing. There is no wait list for our program. So through HealthNet, say hypothetically, someone has LA Care. We tell them to call LA Care because we honestly have no idea what they're doing with their program, and they might not be doing anything. But we know through HealthNet exactly our program. And so if that person has HealthNet or they switch to HealthNet, then when they switch over, it takes effect at the beginning of the next month. So say they switch over July 30th, July 27th, they can be enrolled with HealthNet by August 1st. We're not telling them to switch managed care plans because we don't care about that. But we're just saying, we know for our program is up and running. We just don't know what LA Care is doing. But our program doesn't have a wait list. So say the person has HealthNet. We have a bunch of forms to fill out, and I'll show you our links. But once all that's filled out completely, it's what we call a referral package. And once we send a referral package, HealthNet has 5 days to authorize that person or deny them. But we're very good about the people that we send in, so they should most likely be authorized. then from that point, we can place them immediately because we're working with our network. We're not limited to ALW because it has nothing to do with ALW. I'll show you. I just want to show you. Let me go over. Let me see if I open this, if this works. If not, did that work, or do I have to open up another screen?
No, it didn't do
Oh,
it.
Okay, so let me stop this one. I want to stop share, and let me open up this other screen. By the way, I know I've gone on and on, so I don't know if we have a time limit, but I'm getting close to the end, so if
Yeah,
bear with me.
yeah, we're starting to lose people, so.
Okay, give me another 2 minutes and I'll just finish up. So we have actually on our website.
Your website's very thorough. I mean, I was amazed at all the information there is on it.
Thank you. Do you see this?
Yes.
Okay. Our website is carehomefinders.com. And on our website, if you go to CalAIM, we have what's called our pre-referral package. And this talks, and do you see the page that says pre-referral package? Is that what you see?
Yes.
Okay. So we explain about the program, the assisted living portion, the room and board portion, the eligibility, what the rates are for 2024, how we send an authorization, and then what we like for our referral package. Declaration of eligibility. Ideally, Dr. So-and-so says Mrs. Johnson, who wanders, is at risk of being prematurely institutionalized. That's what we like from a doctor. We don't have to have it, but that is nice. Or from APS, we've gotten repeated calls, this person is wandering. So that's called a declaration of eligibility. Physician's report. Every home before you're admitted has to have something filled out called a 602, where a doctor says, this person needs help dressing, this person needs help bathing, this person. So that's called a 602. So for private placement or through CalAIM placement, it doesn't matter. Every home needs this form filled out before they're placeable. And then we have some other forms. I authorize Jason to start looking for places, liability form, form for a room and board. Because some people will notice through the program will not want to pay the room and board portion. They'll be like, I'm not going to pay you. I'm not going to pay the home. And that becomes a big issue because the home depends on that room and board portion and the Medi-Cal assisted living portion. So we have a form that I, so-and-so, or family, we will pay the room and board portion, whatever, a legal form, they can still say no. But we're trying to give them some protection because they're only taking the person because they can get the room and board and they can get the assisted living portion by Medi-Cal. And those two portions together pay market rate. And then we have form, who are you applying for the program for, what's the managed care name, who are you referred by? So this is all the stuff that eventually we'll send in to HealthNet, and we'll see what Kaiser does with their program, but hopefully Kaiser will adopt this format as well. So we develop what we call a package, and our package was completely developed. And actually, curiously enough, HealthNet actually wants us to find the home even before we send in the referral, which is kind of weird because we wanted two authorizations. One, authorize this person, and second, authorize payment for the home. But HealthNet says, no, we want to make it easier on us. We want you to do everything. We want you to find the home, make sure the home wants to work with us, send in everything, send in the national provider number for the home. So it's a little bit more work for us. So we actually have to manage the payment. The home send us their invoice. We send the claim to HealthNet. HealthNet pays us, we pay them. We've never done this before, and we're learning how to do it. So they basically want us to manage a lot of payments. Imagine, like, if we have 10 homes or 20 homes, we're managing tens of thousands of dollars of payment per month. But that's cost neutral because whatever we get in for that portion, it goes out. But anyway, that's what HealthNet wants us to do. So that's CalAIM. So I've gone over what we do as a private referral agency. So if someone calls us, dad needs help dressing and bathing, he's incontinent, what's your budget, what's your area? Fine, not a problem. So we can usually come up with ideas in a half an hour to an hour. I mentioned the assisted living waiver, which is that program that has a long wait list, well established, great program, but there are certain criteria. Homes have to be Medi-Cal certified, nursing diversion, 3,500 people on the wait list. And then I mentioned the CalAIM. So CalAIM is this new program that the state began, 2 parts, community supports, 14 different components. Managed care don't have to offer all the components. And then enhanced care management, which is help someone stay at home or the services they need. And then I mentioned through CalAIM, the criteria, nursing diversion, nursing level of care, nursing home transition, you have to be in long-term Medi-Cal for 2 months. And eventually the state will come out with fiscal incentives because, like I said, we're very friendly with the state, but we're like, if you're not giving fiscal incentives, the managed care plans will not use the community support for nursing home transition. And when we start marketing the program, and honestly, we haven't, because we don't want to load up only on nursing diversion. So you're like the first group that I've really spoken about CalAIM through HealthNet, and I haven't really marketed it anyplace else yet, because we want to kind of get the balance from nursing home transition, diversion, and just not load up the program with nursing diversion. But it's an amazing program. So that kind of answers, Bruce, your question about if you run out of money, what do you do if you're Medi-Cal, so now assisted living waiver, we know the issues, long wait lists. If you're coming from home, you run out of money, unless you call APS, which is the clever backdoor approach. I think the community support has a lot more advantages, much wider boarding care assisted living network. By the way, that's how we're doing it. I have no idea what LA Care is doing. If they're, I honestly can't tell you if they're copying LW, if they're calling the rate table. I don't know why after 2 months of calling, even emailing the directors, they just can't answer the questions. Are you copying the LW rate tables? Are you developing your own like boarding care network? Really easy questions. They haven't answered the question. So I'm just saying that because LA Care owns like 70% of the market in LA. So, but we're with HealthNet and we've helped them develop their program. So we know exactly all the components. And with Kaiser, which is huge, hopefully they'll copy the same format because we don't have to reinvent the wheel. Anyway, that's my long spiel. I know I've gone on and on and on. Any questions?
Yeah, I've got just one to clarify. Your services are dealing with people who are on Medi-Cal.
Well, no, 2 parts.
No.
Private business,
Well,
35 years, private placement agency. That's how I met Wayne. We're applied, but there's another component that now we're contracted with health.
okay. When you're talking about HealthNet, Kaiser, Molina, and LA Care, those are Medi-Cal providers.
Well, Medicare,
Medicare, like Medicare Part C, also.
Well, they're Kaiser is obviously Medicare, mostly Medicare, right? But they also have some Medi-Cal people, HealthNet, but they're for the purpose of CalAIM, we don't care about the Medicare part. We just care about the Medi-Cal part. So actually, that's a good question. Say someone, for instance, I'll just pick LA Care, for example. And they call LA Care, and LA Care says, our program has a long wait list. We haven't really developed the system. If that person switches to HealthNet, not that I'm advising it, but if they switch to HealthNet, they're only switching the Medi-Cal portion. Medicare is with whoever you want. CalAIM has nothing to do with Medicare, which is more important because Medicare provides, you have a doctor you like through Medicare, you like Kaiser, but you're only switching the Medi-Cal portion to access the community support that you want. Maybe an HMO doesn't offer that community support, but another one does. But our business, 99% of my business is helping place people, private paid boarding care. I get my placement fee, but I'm very excited now to complement that to help low income people because every other call is someone who's low income. And I'm really involved in public policy and working with the state because I really want to help as many people as possible. And CalAIM is going to be huge. Imagine LW has 13,000 people on it, but CalAIM is going to be even bigger eventually because the homes, again, allow people with the Medi-Cal share of cost. There is no wait list. and we can build a bigger network. We can work with any home because they don't have to be Medi-Cal certified. So eventually,
Okay,
CalAIM
so
is huge.
so if someone from the village were realizing that they needed assisted living, nursing home and stuff, they could come to you, and depending on whether they're self-paying or Medi-Cal combinations, you would be a place for them to start the discussion. Is that
Right. Now,
correct?
for the Medi-Cal part, just remember, if they have Medi-Cal with someone that we're not a contractor provider for, of course, we'll refer them to the right number. But in that particular case with CalAIM, LA Care is 70% of the market. And then we work with health and then eventually Kaiser. But yeah, so our job, we help everybody. So someone needs nursing. We'll say, here's resources to get a list of nursing and the ratings. But I am not qualified to say that nursing was amazing because it's too hard to track. The state is coming in, they're issuing new violations. But chances are that person probably doesn't need nursing. They could be custodial care. The problem is budget. Because with the low income, then we're back to the assisted living waiver or CalAIM. So that's what we do. Any other-
Toby, you have a question? Toby?
You're muted, Tobin.
I think it's been answered by what Bruce is asking, but it's just a little of, I'm confused. Or in part, the two programs that you have been talking about today are dependent on the person being enrolled in Medicare, Medi-Cal.
Medi-Cal.
Okay, okay, good. Thank you. And that you serve all kinds of people, but these two programs that you're focusing on today are Medi-Cal.
Right.
Okay, great. Thank you.
Good.
Right. Any
Excuse
other?
me, I have a question.
Sure.
Jason, if a person has a managed care plan, Blue Shield and Optimum, that does not qualify you for CalAIM?
No, I think they have their own programs, but I honestly have no idea the evolution of their program. The
Okay.
problem is that the state didn't issue really any guidelines. And this is a huge issue for us. When I mentioned the Inland Empire Health Plan, they were telling us originally, we want to pay the homes $400 per month. And we're like, that will never work. Like, why would you pay them $400 per month when like even ALW is like $100 per day, like 8 times that amount per month? No, that's how much we want to pay. And us as a community support provider, we're like, how can we ever find out that's going to work with your program? Nope, this is what we're doing. This is the program. And so that really fizzled because we got back to the state and said, if you don't give any minimum guidelines, how do we develop any network? And many other issues with IHP, which is why it's much easier just to copy ALW. It's well established. Why do you need to reinvent the wheel? So that's why I don't know what Blue Shield is doing. I don't know what in Orange County Optum, these other groups are doing. I know they all have this community support, but every plan is completely different, which it shouldn't be, because when you think about it, if the state wants to make a seamless Medi-Cal seamless, why don't they have ALW be in harmony with the community support? Like, because you imagine now, Health Net says we're going to pay ALW rates, but another HMO says we're going to pay half that. Well, then how do they develop their network? Why would that board of care want to work with this other HMO? And or if someone says through Health Net, I'm allowed to pocket that money. If I don't have a Medi-Cal share of cost, cool. I get $2,500 per month. I'm going to pocket. I only need to pay 13. I'm going to pocket that 1,200. And like LA Care doesn't do that. So why wouldn't you switch to Health Net, right? Because you could pocket, which like it's fine, like it's better for us, I guess, but like if there's no fabric that's sort of united, like it's just going to be like the Wild West. And that's our discussion next week with the state. Like you're not giving any minimum guidelines, like give some guidelines for, anyway, what the state has told us a few times is that we're like a huge like whale, and we don't have that little nitty-gritty stuff that you have in the trenches. But it's very frustrating being in the trenches, and it takes forever for the state to make changes. It takes forever. So even for fiscal incentives, you want this program to be big, you're spending billions of dollars for this program to be successful. In San Marino Riverside, you've had 10 people, only 10 people in like 3 years, 2 years the program existed. Why do you think you have so little people?
Do people
in
know
LA,
about it?
In
Are
LA,
managed
like,
care plans promoting it? Are managed care plans promoting these community support affordable housing for seniors?
I mean, they should be. For HealthNet, I get a feeling that they haven't really marketed any part of our component. And honestly, that's not such a bad thing because we're still just waiting to make sure that we get paid back. When we bill for a home, we need to make sure that we get paid so we can pay the home. And now we just finally got our first check paid for a home. Like I said, we've only placed one person.
Yes.
So I know that we're going to have a lot of marketing, but I want to take it slow to make sure all the kinks have been worked out. And then we'll see what happens with Kaiser. Because, you know, I'd love to market this. Imagine like you have friends, you know, people and, right? It's a great program. They have LA Care. Okay, call LA Care. What are they doing? They're doing nothing. So I guess they're all marketing at their own speed, but I don't think HealthNet has done much to market our component yet because we're still figuring out all the pieces.
Thank you.
Any other questions? We need to wrap it up pretty soon. Oh, Kayla?
There we go. Is there an advantage to signing up for Medi-Cal now when I don't need it? Don't worry about it. I don't know either, so keep it in mind.
I guess it would be what Medi-Cal services, how much your income is and what Medi-Cal services you're looking for. Like if you're taking, when you say for yourself, I was going to say if it's for someone who needs PENS or IHSS, but I honestly don't know what direction, what's the purpose of Medi-Cal? I don't know if you know the answer to that, Wayne. Like, can you apply for Medi-Cal if you?
Well, I mean, anybody can apply for Medi-Cal, but they go by the criteria of income and assets. Well, not so much assets anymore, but income definitely. If you're not eligible, even with a share of costs, which is if your income is, a little bit above their limit, then you wouldn't get Medi-Cal. So there would be no advantage to applying for it if you know that you're not eligible for it.
Or if your share cost is too high, like why would you do that? Because you get 4,000 income per month and your share cost is 2,500.
Yeah, I mean, they would just laugh at you. Right. What are you doing here? You got 4,000.
10 years from now, when I'm really old and decrepit.
Right.
Yeah, no, usually Medi-Cal is the insurance of last resort and people can't live without it. So
because I don't have it, so fine.
Yeah, so if a person can live without it, that probably they're not eligible.
Okay.
So this has been recorded. I'll send Wayne the link to the CalAIM site because I think it's pretty interesting. If you happen to have any people that might be interested that just let them know about the program or our website. But I'll pipe all the information to Wayne.
Okay, yeah, and they can certainly contact you at carehomefinders.com.
I also put your website in the chat, so if you guys want to look, just get it from there. Specifically the CalAIM portion, if that's helpful to anyone.
Okay, all right. Well, now that we've windowed everybody down to 16 people, the diehards stuck through the whole thing. Those who didn't have luncheon appointments. Okay, well, thank you very much, Jason. That was certainly, we certainly went deep into the weeds of Medi-Cal waiver program.
I know.
I'm glad that somebody is paying attention to it.
No, I appreciate having an audience because when I tell my wife about this, her eyes roll. She's like, Medi-Cal again? Like, this is so cool. She's like,
I want a divorce.
So I appreciate. Thank you for allowing me to share this.
Thank you, Jason.
Thank you.
Thank you, guys.
Thank you, Jason.
Thank you, Jason.
Yeah.
Thank you.
All right. Goodbye, everybody.